Thank you. Hi friends, we come to our next lecture in gastrointestinal diseases, and that is typhoid. D is missing. D has been eaten up, or D. See, typhoid is a disease which classically we've heard. You've heard in microbiology where they're talking about stepladder fever, diarrhea, and vomiting, all these conditions which are there. So we'll discuss this in detail about what we have regarding typhoid and how typhoid. We talked about last time about cholera and how cholera has been controlled in our country. Cholera now is not a very major disease, and especially so in our country. We have to give credit to our country, which has Kumbh Melas, and despite having huge gatherings of people, we have managed to control diseases like cholera. So gastrointestinal diseases, it is very important that we ensure what we call the sanitation barrier. I will talk about sanitation barrier during this class. But remember, we told you this in third, fourth term, sanitation barrier. We are now talking about it during COVID time. We're talking about hand washing. Most important thing as far as sanitation is concerned is hand washing. So we'll talk about it in a little bit of detail now. So now, I'm sorry, this particular slide on display is showing a little off, but that's how it is. Typhoid fever is due to systematic infection mainly by Salmonella typhi, and Salmonella typhi infection is found only in men and women, but in humans it's not found anywhere else, and that's how the disease is classically characterized by a typical continuous fever for 2 to 3 weeks. Continuous in the sense the fever comes. We know about the fact that there is a stepladder increase in fever which is there. There is relative bradycardia and involvement of lymphoid tissues and considerable constitutional symptoms. Now, the word enteric fever as a whole includes typhoid and the paratyphoid fevers. Now, typhoid and fevers, these can occur either sporadically, or it can be endemically, or you can have an epidemic. The epidemic is if you have contaminated water in a particular source of water which is contaminated, you can have an epidemic which suddenly comes up. We have heard a lot about how typhoid carriers were there, so we'll talk about that. I'm sorry, these slides have all gone haywire with this particular display, but anyhow, I think you can recognize what is there. The agent is Salmonella typhi is a major cause of enteric fevers. Paratyphoids are infrequent. You've seen all this during your microbiology class, so I will not go really into detail. It belongs to the genus Salmonella, belong to Enterobacteriaceae, facultative anaerobe, gram-negative bacilli, distinguished from other bacteria by a biochemical and antigenic structure. You're well aware, you're the past your microbiology, so no need of going into details for that. 3 antigens, this also has been taught to you in microbiology: O, H and VI, number of phage types. It survives intracellularly in the tissues of various organs. It is readily killed by drying, pasteurization, common disinfection. This is important as far as our prevention is concerned. Remember that it gets killed by drying, pasteurization and common disinfection. So we are really not looking at a very major disease which cannot be killed by normal procedures. What is normal procedures? If you get milk in our country, if we get milk, we boil it. So there's not even pasteurization. We're boiling it. We nowadays are consuming mainly pasteurized milk. Villages, you still have people consuming raw milk, but even in the villages, it is now commonplace for boiling the milk. Water is the main source of problem which is there. And for that, our common disinfectants of water like chlorine is the one which will help us to control this illness. The factors which influence onset of typhoid in man are two: the infecting dose and the virulence of the organism. In any illness, if you look at everybody's talking about COVID. Why is it that COVID today is causing less deaths in India or less deaths in the world? It's a normal feature. It's a normal feature of any disease or any bacilli or any virus. When it newly comes in, the maximum damage is done at that particular time. The body then gets adapted. The human body or the genes get adapted to this particular virus or bacilli, and this adaptation will result in the virus becoming less virulent. Also, the importance of the infecting dose. The dose, I'm now taking the example of the COVID virus. Why is it that when we go and speak to someone who has got an infection, you're not likely to be getting the disease if both individuals are masked? Because the infecting dose, even if it takes place, even if an infection takes place, the infecting dose will be very small. So the infecting dose and the virulence of the organism. Every organism, as we're talking about COVID, repeated passages through human beings will generally make any virus or bacteria less virulent. This is one of the theories which is there, one of the hypotheses. So we do hope that we have a less virulent COVID virus roaming around, which can result in less number of deaths, so less number of critical cases. In the case of typhoid also, we're looking at the infecting dose and the virulence of the organism. The reservoir of infection is only man and man only. So basically we're looking at cases and carriers. Carriers is a big chunk over here in typhoid. The cases is infectious as long as the bacilli continues to appear in the stools. So you have carriers. Carriers can be different types. You have incubatory carriers, convalescent carriers. Both of them are classified as temporary carriers, or you have chronic carriers. So when do we call an individual incubatory carrier? Is very simple. During the incubation period, the person has the virus, is asymptomatic, can transmit the virus. So incubatory. Convalescent for 6 to 8 weeks, after which you find that the number of bacilli go down. But this can go on till about 3 months. Persons who excrete the bacilli for more than 1 year after a clinical attack are called chronic carriers. And the classical chronic carrier which we keep talking about was talked to you when you did your microbiology also, they must have mentioned. And that famous chronic carrier which we had was typhoid Mary. We'll talk about typhoid Mary shortly. In most chronic carriers, the bacilli exist in the gallbladder and the biliary tract. And the chronic carrier may excrete the bacilli for several years. As long as even 50 years, the person can keep on excreting because it's then growing in the gallbladder and you keep on excreting the bacilli. So there you are. Typhoid Mary. Typhoid Mary is responsible for 1,300 cases. I'll repeat the story which you must have heard of in microbiology. Typhoid Mary was an excellent cook. She used to go to a number of houses for making food, and she was an excellent cook and she used to make the food. Unfortunately, she didn't have very hygienic habits. She used to not wash her hands, and when she used to not wash her hands, she managed to transmit the disease. She managed to transmit typhoid to 1,300 cases. Fecal carriers are the most common, and then there can be urinary carriers. Now this is the newspaper listing of Typhoid Mary during those days, and the primary source of infection are feces, and in case of urinary caries, the urine. The secondary sources of contamination is water, food, fingers, and flies. Did we cover this in third term? Food, finger, flies. Yeah. Okay. The host factors. And what if you remember what he told you in third term? Food, fingers, flies, and you transmit the bacilli or bacteria, resulting in contamination, and then the host gets the disease. The way of cutting it down is through a sanitary barrier. The sanitary barrier is basically wash your hands in this particular case. Okay. Age, you see, it can occur at any age. Males are more affected than females, possibly because they tend to go out more, tend to have food from other sources more. That's possibly the reason. All ages are susceptible. The host factor that contributes to resistance to the bacilli is basically the gastric acidity. If you eat it and your acidity is good, I mean, if you have a normal acid reaction in the stomach, the bacilli should get killed. There is also local intestinal immunity which will be there, which can possibly prevent the disease. The environmental and social factors which are there, it is there throughout the year. The peak incidence is July to September. Why so? Why so? The reason is simple. It is basically the months when there is monsoon, when there is contamination of water, contamination of sewage in water which takes place. These are the times when we have more cases of enteric fever coming in. This is something which is very common nowadays in our country. You see, we are using sewage water for farmlands. Also, the same water is used to wash the vegetables by the people who sell the vegetables. So, and this is going to become more and more common. You see, I'll give you an example. You think that sewage water is being used very less. Give an example. If you are staying in a colony which has got a sewage treatment plant, or rather let's not go to there. Let's go here to your college. Your college uses sewage treated water for gardening. So all the garden water is sewage treated. So if, for example, you wash your hands in that water, you're likely to get various gastrointestinal diseases. So please do not wash your hands in the water of the garden. And please, whenever you go around and see a gardener, please advise him, please do not run the water without wearing gloves. You can contaminate his hands. If he's got an ulcer, you can get an infection, ulcer on his hand, you can get an infection in his hands through the water which he's using for gardening. Okay, so vegetables grown in sewage farmlands or washed in contaminated water are cause for concern. Typhoid bacilli also, the best source is considered to be milk. Grows very well in milk, so it doesn't alter the taste also, and especially during the summer months and all hot and humid months which is there, you have contamination of water, contamination of milk is very, very common. Also, as I said, contamination of drinking water, open air defecation. See, as far as the government is concerned, there is no open air defecation in the whole country. As far as we are concerned, we know that open air defecation still continues in our country. Open air urination takes place. I don't know, you find a huge number of, you go around the countryside, you find people just going around any wall and urinating over there. Do you find any person, I rarely find a person who urinates and then goes and washes his hands. He's back onto his job after that. It's our poor standard of hygiene which we do not train our mainly males who go around go and urinate in the public and don't wash their hands after that. hepatitis infection, there is the likelihood of infection. There is poor personal hygiene. Typhoid fever may be regarded as an index of general sanitation in any country. The incubation period 10 to 14 days, while it can be as short as 3 days and as long as 3 weeks, depending on the dose of the bacilli ingested. Mode of transmission, as we mentioned, typhical or urinary, basically through soiled hands or urine, contaminated water, milk, flies. This is the thing which I was mentioning to. Feces and urine from cases or carriers through water, soil, flies and fingers can contaminate foods, raw or cooked, and can come to the mouth of the person concerned. So, what we can do is, right at this particular place, if we wash our hands, if you wash your hands, neither water will get contaminated nor soil will not get contaminated. Of course, if we don't do open air defecation, in all these cases, especially the most important one being the fingers, you have a sanitation barrier which can be applied, and you can manage to ensure that there is no fecal or urinary transmission. Clinical features, basically it's insidious, but in children you may have chills and high fever. During the prodromal phase, like any other fever, you have malaise, headache. You may have a cough or sore throat, not very common. You may have abdominal pain, constipation. The fever ascends in step ladder fashion. Now, let me tell you, these are classical descriptions. Step ladder pattern. Rashes, we'll talk about rashes shortly. All these things are rarely seen in our country, or in any country for that matter nowadays. What happens when a patient has fever and comes to a quack or a doctor? He's given paracetamol. So you're not going to see the step ladder pattern. What happens when a person who has fever goes to a quack or doctor any doctor who does not know the diagnosis also? The first thing which they do nowadays is give antibiotics. If you give antibiotics, you are not going to be able to see the natural history of this disease, and you will not be able to diagnose the disease. We'll talk about immunoglobulins also a little later. Giving antibiotics will also cut the immunoglobulin, the formation of immunoglobulins. The diagnosis of the disease hence gets hampered also. We'll talk about that a little later. After about 7 to 10 days, the fever reaches a plateau and the patient looks toxic, exhausted and prostrated. And after the constipation, the patient generally has diarrhea, which is typically called a pea soup stool. What was that in cholera? In cholera we had rice water stool. In typhoid we have a pea soup stools. Marked abdominal distension, what you call, patient will keep on telling you there's gas in the tummy, abdominal distension takes place. There's leukopenia, very very important to look for leukopenia. Leukopenia is a classical feature of typhoid fever, leukopenia. While most other diseases you will find leukocytosis, while in typhoid you have leukopenia. Blood, urine and stool can be positive for salmonella. If the patient improves within 7 to 10 days, he will not have any complications. However, relapse may occur for up to 2 weeks after termination of therapy. Early phase physical findings are few, but if the patient continues to have typhoid, then you have splenomegaly, abdominal distension, relative bradycardia, dichotic pulse, and may also sometimes have meningitis. Okay, this is the rash which I was talking about. Rash, rose spots. What rose spots in our country? We have wonderful skin which is dark in color, not as dark as a Negro, but we have a nice dark skin. People come to our country to develop, all these people from the West, they come to India because they want to get tanned. We are born with a tan, and then what do? We use Fair and Lovely to become fair. It's a problem with the culture. So rose spots, very difficult to see in our country. In our country, very difficult with our tan which we have, difficult to see rose spots. So don't look for them. Do look for them, but if you don't be disappointed if you don't find them. So the spot, if it is found in fair individuals, found principally on the trunk, pink papule 2 to 3 millimeters in diameter that fades on pressure, disappears after 3 to 4 days. So these are the patches which are there, mainly seen in fair-skinned individuals. You will find these patches. In Indians, you do not find much of it. You may find some of it, but look for it. Do find it good. Serious complications occur in 10% of people, especially who have been ill for longer than 2 weeks and who have not received proper treatment. Not common nowadays. Complications are not so common nowadays because the first thing which you do with a patient with fever is to give antibiotics. Intestinal hemorrhage is manifested by sudden drop in temperature. Basically, it is hemorrhage. It's not the thing. The person goes. What happens in a hemorrhage? When a patient gets hemorrhage, he goes into shock. What are the features of shock? Cold, clammy skin, thready pulse. These are the features of shock. So, when you're talking about cold, clammy, the temperature will drop. Automatically, you're talking about temperature dropping. So, basically, the feature of the hemorrhage rather than the feature of the disease. Intestinal perforation is most likely to occur in 3rd week. Less frequent complications which are there are urinary retention, pneumonia, thrombophlebitis, myocarditis, psychosis. We talked about meningitis, psychosis, cholecystitis, nephritis, and osteomyelitis. Fortunately, with antibiotics being given early for any fever by the quacks or by private practitioners, we do find that these complications are much less. But as we talk about later, today typhoid has become resistant to the normal treatment. Normal treatment used to be chloramphenicol. That it's resistant to chloramphenicol. We'll tell you what to do. So lab diagnosis, what is the lab diagnosis for it? The definitive diagnosis is by isolation of the bacilli from blood, bone marrow or stools. So blood culture is the mainstay for diagnosis. You have a Vidal test which can be done, and there you have got a agglutination of the antibody for the O and H antigens. Usually the O antigens appear on day 6 to 8, and H antibodies by about 10 to 12. But remember that if you give antibiotics early, what are you looking at? You are looking at an increase in titer. So you must take the serum sample on day 0 first, and then look at the sample after a few days to come to a diagnosis. And what you're looking at is a 4-fold increase in titer. A 4-fold increase in titer, or a single reading of 1/160. Test is usually performed on acute serum. At first contact with the patient, test has moderate sensitivity and specificity. That's the problem which is there. And the reason again is because of early antibiotics being given. Maybe negative in up to 30% of culture proven cases. Culture is the one which is the gold standard. You take the sample and culture it. Basically, it's because of prior antibiotic therapy which blunts the antibody response. There is this rapid diagnostic test with the Tubex test which is there, which is come for antibodies, typhoid lipopolysaccharide antigen and staining of bound antibodies by anti-human IgM antibody conjugated to colloid dyne. These are the newer tests which are being done. So diagnosis basically by doing a feces culture or Vidal culture or urine culture. So the first ones which will be positive will be first you should take a blood and a feces for culture. Vidal basically being an antibody test, it takes a few days for coming on. But what we can look for is the initial antibody test and a 4-fold increase in titer which we are looking at. Urine cultures generally come a little later because infection generally is first in the intestines, then we are looking at blood, and then it will travel to the urine. So what do we do in control? The control or elimination of the typhoid is easy. What you're looking at is control of the reservoir, control of sanitation and immunization. What do you do as far as the reservoir is concerned? You have to identify, isolate, treat and disinfect. Basically, the most important first is to identify the source which is there, isolate, treat and disinfect. Early diagnosis is very, very important. So once you have the early diagnosis, then you can look for you can do, how do you do that? With a blood or stool investigation. And very important to do notification. You must notify typhoid cases, must be informed, and isolation of these cases is important till the time the cultures are negative. As a rule, a person should be isolated for 3 bacteriologically negative stools and urine cultures, which should be done on separate days. Treatment. Now the treatment of this disease is by fluoroquinolones, drug of choice. Earlier we used to have chloramphenicol as a drug of choice, but today, because we have got a resistance to chloramphenicol which is taking place, we are now looking at ciproflox, Oflox or ceftriaxone as the drugs. First drug which you should try out is ciproflox, which is generally given in a dose of 500 mg BD or 5 to 10 mg per kg BD. So these can be given. You have various doses which are mentioned in the slide over here. For severe typhoid, you would again try out ciproflox, ceftriaxone and cefotaxime. This or a combination of these as is given depending on the culture reports. So you can use these things. These are the ones which are now being used, because do not use chloramphenicol now. Chloramphenicol, most typhoid bacilli today are resistant to chloramphenicol. I wouldn't say they are inexpensive, but the ones which are inexpensive are ampicillin, amoxicillin and Septran. These are the ones which are also commonly used, ampicillin, amoxicillin and Septran. These are inexpensive and can be tolerated and are quite reliable. Patients seriously ill and profoundly toxic should be given steroids for 3 to 4 days. Please, the slide is not supposed to be there because I would not like you all to give steroids. There are certain criteria laid down for toxic cases, profoundly toxic cases, and those cases only we should give steroids. Disinfection. Stool and urine are the sole sources of infection, so what we must do is disinfect it. Simple disinfection, 5% per sol, keep it there for about 2 hours, and then flush it down the drain after that. That is so this is what can be done for disinfection. All soil clothes, again, you must put in a hypochlorite solution and steam sterilize it. Doctors and nurses should disinfect their hands. Follow-up should be done for 3 to 4 months after discharge, and again 12 months to prevent development of carrier state. What do you do? Stool and urine culture. For carriers, you are looking at to find out what is the source of infection, identify them, give them treatment for radically controlling the typhoid fever. Identification basically by culture. You would like to do the stool and urine cultures. If you can get a duodenal drainage and you can then do a culture. Antibodies, if they are present, antibodies generally present in 80% of chronic carriers. Treatment for carrier state is ampicillin or amoxicillin 4 to 6 grams a day, together with probenecid 2 grams per day for 6 weeks. Remember, 6 weeks is what we are going to give it to. So 4 to 6 grams for 6 weeks is a long-term treatment which is there, because it's very difficult to eradicate the carrier state. After you do this, wait for some time, wait for a week, and then do a culture. So this is the treatment of carriers again. We have amoxicillin, ampicillin, or you use Septran. 6 weeks. There's another course which is there, ciproflox or norflox for 28 days. These also gives very good cure rate. If these don't get cured, even after all this, you find that the person still is passing a culture, stool culture still shows positivity, you have to do a cholecystectomy. As we mentioned, chloromycetin nowadays is useless even for cases, useless for carriers. Surgery, as I mentioned earlier, cholecystectomy is to be done, and then you start a concomitant ampicillin therapy for treatment of carriers. Urinary carriers, though this is mentioned in the books, but for refracted cases to do nephrectomy for urinary carriers, I really don't think is required. But one will have to weigh the requirement, or consider whether the patient is likely to become infected. Patient itself is likely to get infected due to the typhoid bacilli residing in the kidney. This is a very radical step and a very, very controversial step. Surveillance, the carriers should be kept under surveillance and they should be prevented from handling food, milk or water. Health education is very, very important. You must ensure that open air defecation is not done. Washing of hands with soap after defecation or urination and before preparing food. You see, today with COVID being present, hand washing has become more commoner. Sanitation has become more commoner. We are just reading an article as to what are the benefits of this whole. Has COVID resulted in any benefit? Surprisingly, it has been found that there are less new tuberculosis infections because of COVID. Why? Because people have started using masks. Once they're using masking, if there was universal masking and if you had people who were in contact with tuberculosis cases wearing masks regularly even at home, you would find that tuberculosis infection would be cut down even more drastically. But it has been noticed even now that the number of COVID tuberculosis cases have gone down. New tuberculosis cases have gone down. The number of gastrointestinal diseases have gone down. So there is always a silver lining, where in all cases you must look at the silver lining, look at the positives. COVID is there, but you have various other diseases which are benefiting. We do have bad effects of COVID with the other diseases. We have immunization has gone down, we have various other problems which are there, but these are some positives are also there. Management of carriers continues to be an unsolved problem, because suppose you have a urinary carrier. As I said, I wouldn't recommend a urinary carrier to get a nephrectomy done, though it's mentioned in the books. So crux of the problem is carriers in typhoid. Sanitation is very important, so drinking water supply, basic sanitation, food hygiene, these are all the things which we must look at. Immunization is complementary to the prevention of typhoid and use is very, very important. We had typhoid vaccine which was given since ages. It was a killed vaccine which we had, and that was giving very poor results. We did have the efficacy of about 40 to 60%. We used to call it TAB. I have taken it during my childhood. I have taken it so regularly. And we in the army were very, very we used to want this vaccine to be given to every single person, and revaccinations were to be given every 3 to 5 years. So we did use that, and we did cut down the number of cases of typhoid at that particular time. But today the vaccines are much better. Immunization against typhoid does not give 100% protection, but it definitely lowers both the incidence and seriousness of infection. It can be given at age upward of 2 years. Recommended only in endemic areas, household contacts, or wherever there is risk of infection, school children, or wherever there is large congregation. Like for example, in the army we've got the recruiting centers, etc. We would like to give it over there. Hospital staff, travelers, these are the ones who should take the vaccination. And the vaccines which are available are the VI polysaccharide vaccine and the type 21A vaccine. So the VI vaccine which is there, it's a VI capsular polysaccharide from the TY2S strain which is there, and gives a quite a good response. The vaccine is administered subcutaneously. The target is about, like to give about 25 micrograms of the antigen. Vaccine is stable for 6 months at 37 degrees and for 2 years at 22 degrees. So it's very good vaccine, stable, heat stable vaccine. Recommended storage is at 2 to 8 degrees. The problem is less than 2 years it does not give an immune response, which is good. Only 1 dose is required, and the vaccine confers protection for, you can say after 7 days the immune response starts off, and the best response is about 28 days. To maintain protection, revaccination has been recommended every 3 years, and it can be co-administered with other vaccines. No serious adverse effects are seen, no contraindication to this. The 21A vaccine which is there is a lyophilized vaccine and entry coated, so it's orally, you can take it orally, oral vaccine which is there. So it's very easy to administer. Again, it can be stored at 2 to 8 degrees and retains potency for 14 days at 25 degrees, but better to keep it in 2 to 8 degrees. It is not so heat stable a vaccine as the previous vaccine. Any child who is above 5 years can be given the vaccine. It is administered every other day for 3 doses and gives an immunity after about 7 days again. Recommended is to repeat it after 3 years, and people who are traveling to endemic areas, they can take it. So this is basically this is a slide which has been made by the Ayush people. So if you notice what is below, what has been mentioned: cures, bagul bark tea, guava tree flowers, bitter gourd leaves, and carrot soup. I kept this slide specifically because you see, today we are talking that there should be integration of medicine with Ayush, and we have Ayush giving for prevention of COVID. They gave arsenium, some arsenium compound was given to a huge number of people, and Minister for Ayush is admitted with COVID in Goa for the past 10-15 days. So I really wonder whether there is any science in what they do. But anyhow, since the government says so, that we must integrate with Ayush, this is a slide which Ayush has put up, not to be quoted in our exam. This is only for your knowledge. If you write it in your exam, I'll give you negative marks. Okay, typhoid is basically common sense. Hygiene is most important. Have clean water, and that's most important. Thank you.